Good afternoon, class. In this recording, we're going to continue our study of GU alterations, and we're going to focus on male reproductive problems. As we're caring for male patients that have reproductive problems, it's especially important that we respect the man's privacy at all times and care for them in a non-judgmental manner. We see a wide variety of reproductive problems that can range from short-term infections to long-term health care problems, and even some that lead to terminal conditions. Realize that any health issue that affects the male reproductive system can affect the human need for sexuality. Some of these patients actually experience problems with developing an erection, and some of them have psychological problems that cause them problems with engaging in sexual activity. So all of these conditions we talk about can affect their sex life. The first condition I have is benign prostatic hyperplasia. The term hyperplasia means an increase in the number of cells. And so you can see here in the prostate gland we have tissue that has developed lots and lots of cells. And the result is pressure on the urethra. This leads to increased volume of residual urine, which can cause overflow urinary incontinence, or the patient may also suffer from just unable to pass urine at all. So they can leak and dribble, or they can just have really problems getting started. BPH is a pretty common condition as men age. It's likely related to the influence of androgens that are already present in the prostate tissue. So the symptoms include urgency, frequency, dribbling, urinary incontinence, unable to start the stream of urine. It can also lead to hydroureter or hydronephrosis. This shows you a picture of what the hydroureter looks like in comparison to a normal ureter, and how the kidney itself can get enlarged. So these are some complications and urinary retention and reflux that can be caused by the prostate enlargement. Typically, the lab values that will be done on a patient with suspected BPH include a urinalysis and culture, a CBC, and the kidney function will be evaluated with a BUN and creatinine. A prostate-specific antigen or a PSA test may be done to rule out prostate cancer, and a CNS of the prostatic fluid may also be collected. Diagnostics may include an ultrasound, a transabdominal or transrectal ultrasound, a bladder ultrasound, or a cystoscopy. The goal with anybody that has BPH is to improve urinary output or urinary elimination. You want to do what you can to reduce the bladder being distended, and the first treatment typically is to try different drugs. The 5-alpha reductase inhibitors are prescribed first off, and that some examples are Proscar and Avodart. These help to facilitate urinary flow, but they may take up to 6 months before the patient can actually see any improvement. And they do have some side effects that are undesirable, such as erectile dysfunction, decreased libido, and dizziness due to orthostatic hypotension. Another class of drugs are the alpha-1 selective blocking agents. Flomax and Cordura are examples of these. When we're caring for these patients, we want to teach them to avoid drinking large amounts of fluids in a short time, just to avoid overextending the bladder. They should also avoid alcohol, diuretics, and caffeine. Teach them to go void when they first feel the urge to void. They don't need to try to hold it. The gold standard for surgery is the TURP, the transurethral resection of the prostate. And in this, the surgeon inserts the retroscope and goes in through the urethra into the bladder and removes pieces of that prostate gland. So this shows how that's done. Care after the TURP. The first 24 hours we want to particularly monitor intake and output. Most likely we'll be irrigating the bladder with a Murphy drip. It's a big bag of fluid we hang with that through a three-way catheter where the bladder is being irrigated continuously. This helps to prevent the catheter from clotting off from the blood, from the blood clots sometimes the patients will pass. So care for a patient that has had a TURP, you want to monitor them for signs and symptoms of infection, help them get out of bed as soon as possible, manage their pain, make sure they're safe. Sometimes they'll be confused and want to pull on their catheter, so you want to reorient them and keep the catheter tube secure. Sometimes giving them something else to hold will help them to distract them from wanting to grab the tube. Usually normal saline is the solution used to irrigate the bladder. Monitor the color, consistency, and amount of urine output. Check the drainage tube frequently for obstructions, and keep the clots cleared out with the irrigation solution. Assess the patient for bladder spasms, because oftentimes they will have bladder spasms. And if the catheter becomes obstructive and does not resolve by hand irrigating it, then you need to let the doctor know. And you also need to let the doctor know if the consistency of the output starts to look like ketchup, because that may indicate that the patient's having an arterial bleed. Oftentimes the catheter will be taped to the abdomen or thigh for traction, and the patient's going to feel uncomfortable because of this, because the diameter of the catheter and the balloon pulling against them is going to make them feel like they need to urinate. They don't need to try to urinate around the catheter. Sometimes they'll actually even go home with a catheter. So educating the patient is important as well. Explaining to them what to expect relative to their sexual activities, that this should not impair their sexual activities later. Making sure that they attend to follow-up and continue to be monitored with their health care providers also important. The next condition I have listed is prostate cancer. Prostate cancer is a pretty common type of cancer for males. Usually the men are older than 65 years old, and it affects African American men more commonly than European men at an earlier age. Most prostate tumors are adenocarcinomas that arise from the epithelial cells. It's one of the slowest growing types of cancer there is, and metastasis occurs to the bones, lungs, and liver. So those are the most common areas. They think the cause is related to androgens and diet factors such as eating red meat and complex carbohydrates or low fiber diet. it's very important to teach these men about the guidelines for screening early detection. The current recommendations are that men should make an informal decision about whether to take prostate cancer screening. Starting at the age of 50, men should discuss the options of having a PSA test done annually. If prostate cancer is suspected, they will obviously do a biopsy to confirm the diagnosis. The first symptom may be related to the bladder, neck obstruction, and difficulty urinating. Surgical management is the most common intervention for cure. A minimal invasive surgery or an open surgical technique for radical prostatectomy is the most often performed. A bilateral orchiectomy, or removal of both testicles, is another palliative surgery that slows the spread of cancer by removing the main source of testosterone. Pre-op care depends on the type of surgery performed. Most common surgery is the laparoscopic radical prostatectomy, or what we call the robotic surgery. The patient should be have education prior to having the surgery. After surgery, we want to encourage the patient to use their PCA pump, help them get out of bed, maintain sequential compression devices to prevent DVTs, get them up and ambulate them as soon as possible, keep an I&O, including Jackson Pratt and other drainage devices, keep the urinary meatus clean with soap and water, avoid rectal procedures or treatment, teach them how to care for their urinary catheter, because they're probably going to be discharged with it to wear for a while, teach them how to use a leg bag, teach them to avoid straining during bowel movements, and the importance of follow-up with their doctor. Non-surgical management can be an adjunct to surgery or an alternative intervention if the cancer is widespread. External and internal radiation therapy may be used to treat the prostate cancer or as a salvage treatment when cancer reoccurs. The next condition I have is erectile dysfunction. It's the inability to achieve or maintain an erection for sexual intercourse. It's also known as impotence. Organic erectile dysfunction is a gradual deterioration of function. The man first notices diminishing firmness and a decrease in frequency, and it can be caused by a number of things, including inflammation of the prostate, urethra, or seminal vesicles, surgical procedures, pelvic fractures, lumbosacral injuries, and many other conditions. Drugs and alcohol and smoking also can lead to this condition. First-line drugs to manage erectile dysfunction work to relax the smooth muscles in the corporal cavernosa so blood flow to the penis is increased. The veins exiting the corpora are compressed, limiting outward blood flow, resulting in penile swelling. Teach the patient to take one pill of their medication, and these are PDE5 inhibitors. Take them 1 hour before sexual intercourse. For some drugs, such as Viagra and Levitra, sexual stimulation is needed within 1/2 to 1 hour to promote the erection. Assessment, you want to be sure and assess any medical issues, social history, sexual history issues, find out about the drugs they're taking. If they report this condition, assist with a physical exam, and a duplex Doppler ultrasound may also be performed as this condition is being evaluated. There are some other procedures that can be done for this. Your textbook goes over some of these, including penile implants. The next condition is testicular cancer. It's a rare type of cancer that affects men 20 and 54 to 54 years of age, but it can affect any age. But it usually affects people in the reproductive time of their life. So it has significant economic, social, and psychological impacts on the patients. It falls within two different types of tumors, germ cell tumors and non-germ cell tumors. It's rarely bilateral. Other cancers such as leukemia, lymphoma, and metastatic carcinomas may invade the testes as well. Laboratory assessment and diagnostics for testicular cancer include confirming a diagnosis with serum tumor markers. Oftentimes an ultrasound, CAT scan, or MRI is performed. These patients often have problems with low sperm counts or absence of living sperm. Surgery is the main treatment. Surgery can include a radical unilateral orchiectomy or removal of the affected testicle. Other treatments include combination treatment of surgery and chemotherapy. Some other common problems we're going to talk about are hydrocele, spermatocele, varicocele, and torsions. You can see there the hydrocele is a cystic mass usually filled with straw-colored urine right here around the testes. It results from impaired lymphatic drainage of the scrotum, causing swelling of the tissue surrounding it. The treatment is just to stick a needle in and draw it out. So, pretty simple treatment there. The spermatocele is a self-contained cyst mass on the epididymitis alongside the testicle. It's normally small and asymptomatic, and there's no intervention required typically. If it becomes large enough, though, a spermatocelectomy is performed. The varicocele is a cluster, you can see that here, of dilated, you see this, how dilated they are compared to the others. Veins occurring behind and above the testes, and this can cause infertility. And a varicoceleectomy is performed, removing those through an inguinal incision, and spermatic veins are litigated to in the cord there for that. And then the torsion is where we see twisted spermatic cord in blood vessels. And obviously that has to be addressed as well, or we're going to have a problem with blood flow through surgery. Not going to talk any more about those conditions. You can read more in your book about those. Cancer of the penis is oftentimes epidermoid or squamous carcinomas developing from the squamous cells. If circumcision in infancy almost always eliminates the possibility of penile cancer. It's a painless wart-like growth, and an excisional biopsy may be done, radiation therapy may be done, and penectomy is the treatment, which is partial or total removal of the penis. Post-op, you want to observe the incision every 2 to 4 hours. For the first 24 hours, a moderate amount of serosanguinous drainage from the incisional drains is expected. These patients need a lot of psychological counseling, they're going to have emotional problems, even if they appear to not. Consider the changes of body image and sexuality is quite dramatic. Encourage the patients to express their feelings about this and to seek help post-discharge. Next two conditions I have listed are phimosis and paraphimosis. With these conditions, we've got constricted prepuce that cannot be retracted over the glands, and the prepuce remains down over the tip of the penis. With the paraphimosis, the prepuce has not been returned to its normal position after being retracted, and it forms a constrictive band around the glands. This constricts lymph drainage and causes the penis to swell, and blood flow becomes impeded and tissue death occurs. So these are emergency situations. They require treatment immediately. For phimosis, circumcision is the treatment. Circumcision in an adult male is usually performed in the same day surgery. The patient has a dress and instruct him to soak it with warm water that evening to allow the dressing to loosen. If the dressing falls off before the next day, caution him to not replace it. Explain that the sutures will be absorbed. There should be no residual or side effects resulting from the surgery. The patient should be able to resume normal activities within 1 week. Sexual activity may be resumed in 1 to 2 weeks. Pain is the main problem for these patients. The next condition is priapism. It's uncontrolled, long-maintained erection without sexual desire, which causes the penis to become large and hard and painful. It affects the two corpora cavernosa. The corpus spongia and the glans penis are not effective. It occurs from neurovascular and pharmacological causes, including thrombosis of the veins, leukemia, sickle cell disease, diabetes mellitus, and malignancies. It's a urologic emergency because the circulation to the penis may be compromised and the patient may not be able to avoid with an erected penis. Desired outcome for intervention is to improve the venous drainage of the corpora cavernosa, and conservative measures involve prosthetic massage, sedation, ice packs, and bed rest. Demerol is given immediately because of the hypotensive effect. Urinary catheterization is required if the man can't void. Be sensitive to their emotional needs and maintain privacy with this crisis. The next condition is epididymitis. It's an inflammation of the epididymis resulting from infection or non-infectious sources such as trauma. The treatment is listed there: bed rest, elevate the scrotum, scrotal support even when ambulating, comfort measures, and a surgical procedure may have to be performed as well with this condition. Orchitis is acute testicular inflammation resulting from trauma infection. Again, the treatment is about the same: scrotal support, ice, analgesic, and antibiotics. Most cases of orchitis are associated with the mumps virus. So that's why I had this on this slide. I encourage you to read in your textbook a little bit more about these conditions, as I've not really went into a lot of detail about nursing care. Be able to recognize what your role in caring for these types of patients is. This concludes this recording. Thanks very much.